Can everybody see? Can you see? Yeah. Okay. Thank you very much, Dr. Ben, for the introduction. Since we've got two long presentations, so I'll get straight to it. A little bit about the evolution of COVID. Looks like it surpassed all other whatever potential pandemics that were supposed to come around in a very short period of time. So on the 31st of December, about 27 pneumonia cases of unknown etiology was actually first reported out of Wuhan city in the Hubei province in China. On the 3rd of January, about 44 cases were identified and they were associated with the seafood market in Wuhan. And but then soon we know that on the 7th, then later on they started identifying more cases which were actually not linked to this seafood market. And on the 7th of January, isolation of a new coronavirus was announced, and the genetic sequence was actually shared on the 12th of January, and it led to a rapid development of a PCR test that probably one of the ancestral tests that we are probably using now. On the 13th of January, cases started creeping out of China with countries like Thailand, Nepal, Japan, South Korea, reporting their fair share of COVID experience. On the 20th of January, about 282 confirmed cases of 2019, then called 2019 and COVID, and of which 18% was severe. Sorry, can we hide? You can hide. Oh, sorry. About 18% severe cases were reported, 4% were critical, and the 2% were case fatality. And on the 30th of January, WHO actually declared it as a public health of international concerns. On the 11th of February, the disease was renamed as COVID-19. And on the 11th of March 2020, the pandemic status was finally declared by WHO. Now in Malaysia, our first cases were actually imported, and they were from China, belonging to the first Chinese cohort that were diagnosed in Singapore. Nobody could actually forget the first day of Chinese New Year, and since then about 22 cases were actually detected. Most of them actually had a pit link to China, except for one person who had close contact with a Chinese national in Singapore in a Singapore conference. And since then, we've seen two major waves. One was the Uda Khazana cluster. Our largest wave was actually belonging to the Sri Petaling public groups. That cluster actually identified about 3,375 cases. How do I? Sorry. Right. Sorry. 300. Sorry about that. And since then, we've had several smaller scale clusters among healthcare workers. We have returning travelers, foreign workers, and of course, local transmission cases like the nursing home and stuff. On the 23rd, so since yesterday, we actually have, as of yesterday, we actually have about 8,840 COVID-19 positive cases, of which 96.99% have actually recovered, and we've had about 123 deaths. Now, let's talk about a little bit about how does the disease actually cause complications. Yeah. So the virus basically attaches it's an RNA virus that basically attaches to the ACE2 receptors in the body, which is found in many organs, but primarily very high amounts actually in the lung. But these ACE2 receptors are also found in heart, ileum, the kidneys, as well as the bladder. The disease can cause a severe hypoxemic respiratory failure. It can actually also manifest as a DIC, which is actually marked by a significant hyper-coagulable state. When the disease progresses, it also stimulates sort of like a cytokine storm reaction where the patients actually develop severe worsening of the pulmonary function as well as multi-organ failure. And of course, sometimes the disease worsens purely due to complications of underlying comorbidities. Okay, a lot actually has been talked about regarding period of infectivity. Now, the way we can actually define period of infectivity, we can define it according to microbiological study as well as epidemiological study. So this Taiwan paper looked at 2,761 close contact to index cases, all right? And in this index, related to these index cases, about 22 secondary cases or contacts were actually identified. When they looked at the details of these secondary cases, it was noted that most of them, the exposure to the index case was actually less than 5 days of illness. So whoever who had contact with the case more than 5 days of illness, they actually never identified a single positive case. And 2 of those 22 cases were actually were in contact with the index case during their pre-symptomatic period. This is another study that actually looked at 77 pairs of infector and infectee pairs all around the world. And a lot of people talk about asymptomatic, but this paper basically talks about that probably the high peak of transmission is probably 2 days prior to the onset of the symptoms, which is during the pre-symptomatic period, and probably peaks at about 1 to 2 days after the symptom onset. And they also talked about they probably are not infective after the day 7 of symptom onset. Now, what is the spectrum of clinical presentation and how do we actually recognize these patients, right? So symptoms, this is the IDSA guideline on COVID-19. And basically the symptoms can actually appear, it's got a variable range of incubation period. So for generally, we talk about 14 days. Most become symptomatic by day 11 or so. But symptoms may appear as early as 2 days or up to 14 days after the exposure of the virus, right? And people with these symptoms or combination of such symptoms could actually have COVID-19. So generally respiratory symptoms alone, cough and shortness of breath, or at least they may present with fever, chills, shakes, muscle pain, headaches, sore throat, and of course, anosmia as well. And in Malaysia, in our guidelines, this is how we stage COVID-19. So stage 1, so we call them as, and if you actually look at the even press releases, everybody talks about their stages. So stage 1 is basically asymptomatic patients. Stage 2 are patients who have symptoms, but they have no evidence of pneumonia. Stage 3 patients are basically those with pneumonia. Stage 4 patients are pneumonia requiring supplemental oxygen. And stage 5 patients are generally in ICU, like critically ill with multi-organ involvement, right? This is just a snapshot of a day in Sungai Buloh where I want to let you know that majority of the patients who actually come to Sungai, who get admitted, basically belong to the mildly or moderately symptomatic. So as you can see, we sum up category 1 and category 2. We basically call them as mild symptoms. And 86% of patients are generally present with very mild symptoms, right? And so up to now, this I think is a very good diagrammatic and accurate schematic diagrammatic description of the whole disease. So this is what we see here as well. So the disease basically goes through several stages, right? So you've got a stage 1 where it's a very mild symptoms. It's predominant by viral replication happens here. Patients either are totally asymptomatic or they have very mild to moderate symptoms. And generally, most of these patients belonging to this stage 1 will actually have, will be detected by their RT-PCRs, yeah? And majority of that, 86, the previous slide showed that 86% of them actually have mild symptoms. So majority of the patients do not progress. They probably have a very short stage 1 viral asymptomatic or mild symptoms, and then they just go straight into recovery, much to how dengue is regularly presented in papers. Like, this is how we talk about severe dengue and dengue shock. So similarly, even COVID presents in a similar way. Now, some minority of patients then progress on to a pulmonary phase. Here, the disease probably goes down through the lower respiratory tract, and this is where you can actually start seeing pneumonia. So CT scans, chest x-rays, clinically, patient will start having clinical signs and symptoms of pneumonia, right? Probably antiviral, probably the viral replications probably starts tapering off by here. And this traditionally, it comes on during about 5 to 11 days since the disease onset. In an even smaller number of patients, they go on to develop sort of like a cytokine storm kind of thing, where in dengue we see HLH, right? Hemophagocytosis kind of a reaction. Here, the cytokines are overstimulated, and they again is actually characterized by worsening of respiratory function, a hyperinflammatory state which involves multiple organs, and generally patients by this time they go into ICU, and they are nursed in ICU. And then subsequently, of course, majority of them do recover, but some of them do succumb to this illness at this stage. So I call it the presentation spectrum. So you've got patient A who actually has an asymptomatic mild disease, and more than 90% of patients present this way. And they don't progress, they don't go on to progress into pulmonary phase and the cytokine release syndrome phase. Then you've got the patient B who is actually symptomatic with progressive worsening. So you've got two types. You've got patients who progressively worsen, or you have patients suddenly worsening during the second week of illness. We've seen both. And these patients generally go through the entire phase of disease line, and generally by day 10, day 11, they will start showing severe symptoms if they were to progress on to milder category to more severe category. Now, who are the ones who tend to progress? So those elderly age more than 65, a lot has been written about this, those pre-existing pulmonary disease, patients with chronic kidney disease, severe uncontrolled diabetics, hypertension with cardiovascular disease, obesity patients, and of course, we haven't seen much, actually we have not seen HIV patients, much HIV patients at all. If I'm not mistaken, there was only one patients on transplant or on immunosuppressive patients as well. They tend to have risk factor of progressing to more severe disease. And when does this occur? Generally, most of them progress by the mid of second week. So by day 10, day 11 of illness, they tend to progress. Some progress much faster also. And how do we predict these patients? How do we pick them up? How do we risk stratify them? So clinically, they're going to be, they're going to have shortness of breath on exertion. They will start becoming hypoxic. They'll have persistent fever. Fever actually is quite a significant factor. And whenever fever is there, all of us are actually on our guards in monitoring these patients. And of course, an increasing CRP or a raised CRP, increasing ferritin, or a persistently low or a dropping absolute lymphocyte count. And radiological features are basically multilobular involvement on a rapidly worsening chest X-ray. So when all this is going on, and the patient is typically in the second week of illness, we start thinking that the patient actually has a form of a hyperstimulation syndrome, like cytokine release syndrome. And of course, we also have this patient C category. This patient is the patient where we think they deteriorate fast. So they mimic like influenza. So influenza typically deteriorates fast, and these patients come in very early, and they tend to deteriorate fast during even the first week of illness. By day 4, day 5, we've had a few patients who actually had. So these patients, we think it's not the CRS, and sometimes these patients actually have no raised CRP, or the CRP is just, it's not going up, it's probably just static, may or may not fever, but they are typically having worsening oxygen requirements. So these patients, they may even have a bit of hepatitis, they may even have signs of viral-like illness where the platelet starts coming down, but those are quite rare. So we think these patients probably are the ones which has very active viral replications, and we are hoping optimizing whatever that's available, antivirals, with Dr. Arisa will be talking about, may actually be the aim of treatment here. Now, and of course, we've got the patient D, where the pneumonia is not the problem here, but they have worsening of their underlying comorbid conditions. So you either have people coming in with advanced heart failure, you have APO, then you have worsening of their kidney functions, or decompensated liver cirrhosis, but we haven't seen, or even we've had a few patients who actually come in with an MI as well. The typical findings of a chest X-ray. So a lot of times we are called, we don't have any test available real time. So we are most easily available test is of course a chest X-ray. So lower lobes tend to predominate with peripheral opacities. You may have single or multiple patchy peripheral opacities, and it's usually bilateral findings. But not really, it doesn't really have to be symmetrical. Non-typical COVID changes are basically lobar pneumonias. We've had a few patients who had COVID positive, but they actually came in with lobar pneumonia. Pleural effusion, of course, but you have to be careful here. So this patient may well have COVID pneumonia, but because he has underlying severe comorbidities like end-stage renal failure, end-stage heart failure, they may have pleural effusion. So of course, clinical picture is also very important, and pulmonary edema. So these are not very typical of chest X-ray findings for COVID. So I just wanted to elaborate. So just one case study. So 30-year-old lady presented with confirmed COVID-19 infection. She was actually started on favipiravir because due to persistent fever. So when even though she's very young, she doesn't go into the risk group, but because she had persistent fever, we're all on our guards, and we start favipiravir on her. On day 11 of illness, despite starting favipiravir, she starts developing shortness of breath. As you can see, the CRP is slowly going up here. Absolute lymphocyte count is not really dropping, but it is not recovering either, and the patient actually desaturates. And this is a typical chest X. So this is the day when we started favipiravir, and she was having high spiking temperature. During this time, she was still not hypoxic, but later on, when she became hypoxic, you can make out the peripheral opacities, which is very typical of COVID here. All right. And who are more likely to die from COVID? So I think this was basically done. They looked at patients who are more likely to have severe illness, and it's very clear here, the more older you are, the more likely you are to have severe COVID. And this is basically looked at age being a denominator for mortality. And as you can see, as the age increases, the mortality rate also increases in these group of patients. And having more than one uncontrolled comorbidities definitely has a severe risk of getting severe disease, right? And how do you diagnose COVID-19? So it's important to understand who are the ones that we should be screening for COVID-19. This is basically the minimal amount of patient who actually needs to be screened, and this is what we use in our hospital. So definitely PUI patients we have to screen. These are with patients who had an EPID contact, or residents, workers, or detainees who are living in confined living spaces like nursing homes, prisons, depot, immigration centers, old folks home, individuals from known clusters that are being investigated that don't fit PUI, frequent healthcare contacts, those patients who go for frequent hemodialysis unit, those who are staying in nursing homes, daycares, or frontliners in COVID-19 management, like healthcare workers, or patients who present with viral-like presentation. If you have a patient who actually can't provide any history, just do an X-ray and probably screen to rule out pneumonia, and probably screen all pneumonias as well. At the moment, we're screening all pneumonias for COVID-19. And what kind of screening tests do we have? We've got RT-PCR, we've got serological tests, and we've also, of course, viral culture is never a gold standard, but it also can be used. Right, so NAT testing, PCR testing is basically detecting one or more of the envelope proteins, and of course the RDP gene. The RDP gene is the one that actually catalyzes the enzyme that's used for replication of the RNA. What sample to collect? So IDSA basically says nasopharyngeal, mid-turbinate, or nasal swab rather than oropharyngeal swab or saliva is actually better in detecting SARS-CoV infection. So nasopharyngeal swab is basically slight tilting of the head and going all the way in. And anyone who has had an NP swabs, I've personally never had one, but I think my bosses had their fair share of nasopharyngeal swab. It's no fun, right? And another swab that can be done is actually a mid-turbinate swab. Apparently, is also equally effective. Mid-turbinate swab is basically, apparently you have to tilt your head much more at about 70 degrees or so in order for you to actually get the mid-turbinate swab here. Now, if clinical suspicion is high and this patient is either deteriorating or looks very much like COVID, and your upper respiratory tract sampling keeps coming back as negative, of course, lower respiratory tract sampling has a better yield of getting COVID-19. Yeah. Now, the good thing about RT-PCR is it actually has more weight than a negative test, especially in a symptomatic patient. Okay, because the test actually has a high specificity. All right, so whoever has a high specificity, but of course we have in our fair share once or twice have seen a false negative RT-PCR, a false positive RT-PCR, or a patient who actually presents in a much later part of their illness. Now, the cons of doing RT-PCR is does not distinguish between the stages of disease and infectivity. Right? And so it cannot be used as a reason for discontinuing infection control precautions. Thus, the change in our guidelines to repeat an RT-PCR before discharging a patient. And it also depends on the site and quality of sampling, right? So one negative test should not be used as a rule out in patients who have strongly suggestive of symptoms. And as you can see here, many papers have talked about this, but this is a paper that talked about a single patient which showed that the RT-PCR was positive even up to 63 days after recovering from the illness. So these patients' symptoms actually resolved by day 18. Antibodies all started coming up by day 10 or so. Even viruses are not being able to culture, but you can see that the gene was still, the RT-PCR was still positive by various specimens, up to about even 2 months plus. And the patient is completely resolved. So this concept of CT value, CT value is basically a cycle threshold, meaning how many cycles, I don't do this test, but basically how many cycles need to go through before they actually detect the gene of the virus. So the CT, so the higher the CT value, the lower the amount of virus which is available for them to start with. So basically so they postulate, some studies postulate every 3.3 increase in the CT value reflects a 10-fold reduction in a starting material. So what is a RT-PCR with a high CT value mean? If taken too early, it may be high. So if the patient is just starting the disease and they're going through their stages of illness, an initial very early RT-PCR may be high. So if the patient progresses and you repeat a RT-PCR, you probably will see a low one. But the one that we always see here is a non-viable or a virus. So a live virus is often isolable only during the first week of illness. But after the first week or so, the RT-PCR test might still be there. But if you actually take the RT-PCR and you try and culture the virus, you can't. So this has infection control implications as well. right? As you can see here, as the CT value drops, right? As the CT value increases, the percentage of culturable virus also significantly drops. So any CT value above 30 in Singapore, basically they say any CT value above 30 and after day 11, you're not left with any virus to culture. So most likely these patients can actually be allowed to return to their normal life, right? And we also did the same thing. We took various patients. We took severe patients from ICU. We took mild cases from the clinic, and all of them were beyond 2 weeks of since their disease onset, and none of the viruses were actually able to be cultured. Now, antigen test kits and antibody test kits are a more rapid way for us to get results and allows testing in a very large scale, And the newest antigen test kit apparently has got very good sensitivities, above 90%. And their limit of detection is a CT value of 30, right? Which is about 300 to 400 viral copies. And they have gone on to say that there was no observed cross-reaction between influenza as well as adenovirus. And appropriate cases, you can use RT. I won't go through this list, but this is what they actually suggest us to apply antigen testing kits. Now, the antigen test kits, basically interpretation of test kits, maybe we go through this first. Interpretation of test kits. So it's a lateral flow assay. It's like a pregnancy test line. If it's negative, only the control line comes up. If it's positive, both the control and the T line, the test line is positive. It doesn't matter whether it's a faint line or whether it's a clear rigid line. But if there's a line at the test, it's considered as a positive. And an invalid test is where only the T line, the line just shows at the T test line there. Now, it should be reconfirmed. Actually, the recent guidelines were just released, and they did say that it should be reconfirmed with the RT-PCR. So all antigen test is not confirmed. It's not a confirmation of COVID-19 disease. You still need to do a PCR test, and preferably by using the same buffer solution in order to confirm the infection. So you may have several scenarios that I've actually put here. So if the RTK antigen test is actually positive and the PCR is positive, obviously it's a confirmed disease. But if you have a positive RTK but a negative PCR, the several possibilities are there. It could be that it's a possible intermittent shedding of the disease, and if you repeat the PCR, it may be positive later, or it's a poor sampling technique. Thus, now the directive is actually to do the PCR test from the buffer solution that was actually used to do the RTK antigen. And of course, we've seen some false positive as well. But the decision to call it false positive, you actually need to look at it in a holistic manner. If you have two PCR tests about 48 hours apart, plus the patient's asymptomatic, no epidlink, and of course, when they've looked around the patient, they never found a secondary contact, then I suppose it's everyone is braver to call it as a negative, as a false positive RTK test. Now, we've had negative RTK tests, forgot to add, but PCR positive, we've had this. Now, we're not sure what this means. It could PCR positive, it could be false a positive PCR test, but it could be quite rare, I know, but or the patient could be incubating the illness during this time, or if the PCR is positive, if the PCR is actually positive, we are not sure if it means that the patient is less infective, because previously I did say that an RTK test is actually negative, and you can actually detect up to CT value of 30. So maybe if PCR is positive and RTK test is negative, it could be that the patient is maybe that the patient is less infective, but we don't have data to actually support this at the moment. And oh God, okay, I can't see my slides, but Okay, so basically, sorry for the ugly slide, but I'll just try and see what I can do here. Okay, so antibody testing is another way. There's actually is another way of trying to support our clinical assessment and see whether this patient actually have COVID and so on. It can be used to diagnose infection when patients present with late complications, such as pulmonary fibrosis or so, and it can support our clinical assessment. But timing is everything when it comes to antibody testing. Basically, it detects one or more of the SARS-CoV antigen. So a positive test is basically a COVID-19 infection. But what does this mean? This positive test could mean several things, right? We can't say if a positive test actually means that the patient actually has neutralizing antibodies towards the particular infection or so, right? Because we don't have any data on neutralizing antibody, and by right, you actually need an ELISA test to actually tell you whether the antibodies that the patient actually has is enough to neutralize the infection or not. So we can't say a positive test means that the patient has got lifelong protection against COVID-19 infections. We don't, and we can't use that to actually determine immune practices, and thus it's actually a no substitute for social distancing, wearing mask, and protective practices. A negative test could well mean that this patient has no COVID-19 infection, or this patient could still have the virus, but maybe because you did the test too early, that could be the result why this patient's antibody testing is coming back as negative. And of course, some people actually never mount a response. And right? And this is another thing. This is another paper that basically talked about the pre-test probability. So if you have a negative, if you actually have a negative antibody test, it depends on what happened. Is okay, right? If you have the chances of interpreting a negative antibody test depends on your probability of actually having the infection in the same place. So if you do a negative antibody test on a random person, a negative test does not actually mean it's a true negative test. But if you do an antibody test on a specific cluster where the infection is actually spreading, so a negative test will have a better sensitivity and a better specificity for a given result. And of course, I'm ending the slide by showing an unpublished, sorry, this is not published yet, but we basically did antibody testing on various time intervals in our patient, and it actually looks like second week and third week onwards, they tend to be more positive. All right, so as a summary, it's just not another virus. It's extremely more infectious. There's actually not much effective treatment out there. It's got a higher fatality rates, and it really, really did change our lives. Diagnosis is actually much harder now than before. We may need to take into account, because patients are more asymptomatic compared to our first cohort, our first few waves where the patients are more symptomatic. And they need to take into account clinical presentation, secondary cases, and supportive test results. Patients with risk factors are not the same as increased risk of getting the disease. So patients with co-morbids and all that are at more risk of developing severe infection, but they are not necessarily at risk of getting a disease. And targeting RTK test among at-risk groups probably has a better, we'll probably be able to interpret the test results better. So with that, I end my talk. Thank you.
Thank you, Dr. Yasmin. Sorry. All right. Okay, we will be moving on with the next speaker, Dr. Arisa, and Dr. Arisa will be talking about the treatment. For those of you who have got questions, please do type them out into the Slido platform, and we will take your questions at the end of the session. Thanks.
Okay,
Can everyone see the slide?
Okay.
Okay. So yes, I'm the new kid on the block and also talking about COVID and management, as has been mentioned by Dr. Yasmin before. There's no effective treatments. So we have been trying a few medication and strategies to manage our patient in Sungai Buloh. Okay. So just to recap, we've talked about this before: clinical staging, stage 1, 2, 3, 4, 5, 5 being the most severe. And how do we manage COVID? So for COVID, we have to look at the whole picture, categorizing the patient, risk stratifying the patient, whether they're going to progress in terms of disease. And if they are not, whether we need to offer them symptomatic relief, role of antivirals, role of anti-inflammatory agents, and the use of anticoagulation medication for prevention of venous thromboembolism. So as was also mentioned earlier, about 80% of our patients actually came in with mild symptoms. They were belonging to category 1 and 2. If they are symptomatic, we provide symptomatic relief such as paracetamol, hydration if they are having significant GI losses. And those category 1 and 2 patients, we need to also learn to identify any potential risk factors that will associate with progression of disease, especially during the critical phase. So generally, we provide supportive care and symptomatic treatment, ensure optimal nutritional support because they are in isolation. So we have to provide enough hydration, drinking water, if they need drips, if they're having GI losses, antiemetics, anti-diarrheal agents, maintain and manage fluid and electrolyte imbalances if there's any, and monitor closely in terms of vital signs, BP, pulse rate, respiratory rate, 12 hourly to 8 hourly depending on the categories of illness. And frequency of blood investigation also depends on the severity. So we do baseline bloods, which also needs to include CRP, coagulation, blood culture if there's evidence of other occult sepsis, ferritin, procalcitonin is available, and ABG if the patient appears to be in respiratory distress. So this is actually obtained from the KKM guideline dated March 24th this year. So you can see this is during our early time when we actually advocate using hydroxychloroquine. So you can see that hydroxychloroquine was used extensively across all categories except for category 1. But the treatment evolved based on more evidence, and this is what we are using in Sungai Buloh. So in January, we actually used Calitra monotherapy, and then we use a lot of hydroxychloroquine plus minus combination therapy depending on those categories. In May, that's when the Lancet published the harmful effect of hydroxychloroquine, and we started to use favipiravir as we have that drug here. And finally, in June, hydroxychloroquine has been removed from the guidelines, and we use our backbone favipiravir as the main drug in combination with others if necessary. This is an unpublished data. The study that was done in Sungai Buloh and Hospital Permai cohort, 586 patients with stage 2 and 3 COVID-19 disease who has been prescribed with hydroxychloroquine, and what happened to them. So before hydroxychloroquine, about 8.9% of patients progressed to stage 4 and 5, but after using hydroxychloroquine, about 10% still progress to 4 and 5. So it shows that hydroxychloroquine may not provide any additional benefit in preventing if they're going to progress to stage 4 or 5. So what we use now in Sungai Buloh, for 1 and 2, we are not using any treatment, just supportive therapy. Clinical stage 3, we use favipiravir. That's the dose that we use for about 5 to 7 days. Stage 4, favi plus PI if available and if no contraindication. And stage 5, in addition to the combination antivirals, we also will give interferon beta plus minus immunomodulatory drugs if needed. So what's favipiravir is actually a drug that was invented for use in influenza, and it was a drug used for Tamiflu resistant influenza. So this drug has been repurposed for use in COVID, but bear in mind that it has teratogenic effects, so caution must be applied for patients who are especially women of childbearing age or male who has childbearing women wives. Make sure that they are we do UPT, and for men we need to advise at least about 1 week washout period for favipiravir to prevent the side effects. Another interesting paper that was published earlier this year, whatever treatment that has been proposed, it is more likely to be effective if only given early. So that's why in Malaysia, we have adapted a very good strategy in admitting patients very early as soon as their result is positive, monitor them in the ward and see the disease progression. If they don't progress, that's good for them. But if they progress, we can start treatment early and build up on the treatment strategies as they go along. So in this paper, you're using Caletra. If it's used earlier, patient less likely to progress. So I'll move on to a case study, Mr. MIH. So it's a 26-year-old student returning from Russia. RTK antigen done in KLIA was positive, followed by a confirmatory nasopharyngeal swab PCR in Sungai Buloh. He presented with fever, cough, anosmia since prior to the travel date. And on examination, he was febrile, he was tachycardic. His saturation was about 98% under room air with respiratory rate of 18. He has ground glass changes on the X-ray over the left here, if you can see. And then when you look at the bloods, white cell of 4 with ALC of 1.5 and CRP of 2.2. So how do we categorize this patient? So it's COVID-19 pneumonia category 3 because there's a pneumonia and symptomatic with fever. And what do we do? Because it has persistent fever in the ward and warning sign as well, so we decided to start on favipiravir for 1 day loading dose of 1,600 mg followed by 600 mg BD for 4 days. And the outcome, so patient actually was discharged well at day 15. He completed his quarantine in the hospital and was asymptomatic about 48 hours prior to discharge. So recap, this was showed earlier. So who are likely to progress to category 4 and 5, and when they are more likely to progress, and when do we need to closely monitor. That's the time when I usually will say that this is a critical phase. We shouldn't be complacent and closely monitor these patients. If they have this risk factor, we may need to heighten up our observation and investigation during the so-called critical phase. So for patient who has comorbidities, they other than just coming in with the fever, cough, sometimes diarrhea, in which we can offer symptomatic relief, we need to closely monitor for disease progression, offer antiviral, but also we will start noticing that their comorbidities might become worse. For example, they might come in with uncontrolled hypertension or uncontrolled diabetes, complication of deterioration of comorbidities like chest pain, IHD, MI, organ failure, so they come in with AKI on CKD, and some of them also might progress and develop nosocomial infection. CRS, or cytokine release syndrome. So this little SARS-CoV-2 virus actually can trigger our body in certain group of patients and causes systemic inflammatory hyper-response states with increased production of pro-inflammatory cytokines, which mostly commonly mentioned as interleukin-6, and lead to cytokine storm. And what the cytokine, what this storm does, it increases vascular permeability, alveoli damage, which leads to ARDS and other organ failures as well, where usually the ACE2 inhibitor sits. And IL-6 also predicts respiratory failure in COVID-19. So what are the warning signs that we need to look out for CRS? So persistent or new onset fever, increased oxygen requirements, plus increased CRP, increased ferritin, persistently low or dropping absolute lymphocyte count of less than 1, and high interleukin-6 level if this is available to be performed. And why it is important? We need to have an agent, an anti-inflammatory agent that could halt this process from progressing and causing more damage to the body. So in a study done in UK, a recovery study, they used dexamethasone to show that steroid actually works to dampen the CRS effect and prevent mortality. So in Malaysia, category 4 and 5, we use either Kaletra or Tazanavir plus favipiravir, so combination antiviral for category 4 and 5. If the patient comes in during the first week of illness, we can add on interferon for an additional antiviral effects. Okay, so progress to case study 2, Mrs. PS, 55 years old lady, a returning traveler from Indonesia. RTK antigen in KLIA was positive, followed by confirmatory PCR test in Sungai Buloh. She came in presentation as category 3 with persistent fever, with white blood cell of 7, absolute lymphocyte count is already low 0.6, and CRP is 2.2. With bilateral ground glass changes in the X-ray. So she has, when she came in initially, she has category 3 pneumonia, COVID-19, and was started on favipiravir. At day 5 of illness, the fever persists. The CRP remains at 2.2. The CRP went up. The box is actually meant for an arrow. Okay, CRP 2.2 becomes 6.2. SpO2 under room air drops from 98% to 95%, with PO2 of only 72, and some acidosis. Ferritin goes up, LDH goes up, white cell remains, and procal is 0.3. X-ray worsen if you compare from before. Okay, so at day 5 of illness, she progressed to category 4 with CRS. So we add on steroids for her. At day 11 of illness, so about 3 days after steroids, unfortunately she progressed again. Look at the chest X-ray, increasing oxygen requirement, had to be transferred to ICU, attempted prone positioning on high flow mass oxygen but failed, and finally she had to be intubated. She also has concomitant possibly community-acquired E. coli, with rise in CRP, white cell remains at 6 despite having a positive blood culture. And that's the CT scan. And one of the CT scan was done because we really need to look hard for any evidence of pulmonary embolism. It is a common finding in patients who are critically ill in ICU, but more commonly in COVID-19 because it's a prothrombotic disease. So from her CT was reported as no evidence of pulmonary embolism, but there's organizing pneumonia with fibrosis and consolidation. So she had prolonged ICU stay, complicated with nosocomial infection. Finally, at day 30 of illness, able to be weaned off oxygen, and hopefully she can be discharged by next week. Okay, so case 3, Mr. NT, 55 years old, referred from private hospital, wasn't sure about the EPID link, but has multiple hospital visits and admission to hospitals for UTI. His comorbidities are hypertension, prostate, BPH, and stroke. So nasopharyngeal swab was positive, and when he came in with fever, cough, chest pain, with white cell count of 4, low absolute ALC and CRP of 1.9, and bilateral GTO. So category 3 started on HCQ. This is earlier on in April when we are still using HCQ. At day 5 of illness, he progressed, requiring more oxygen and having persistent fever, X-ray worsened with CRP going up. So from category 3, he progressed to category 4. So we add on second antiviral as well as interferon. At day 7, increased oxygen requirement still. CRP went up from 3.9 to 6.9. Liver function started to become deranged. So from category 3 to 4, now he became category 5, had to be intubated, and decision was made to add on an IV tocilizumab with anti-IL-6 receptor antagonist. Okay, so finally he was able to be weaned off oxygen at day 10. Good response with all the combination treatment. CRP went down from maximum of 6 or 7, went down to 0.5, and finally able to be discharged at day 16 of illness. So national guidelines, category 4 and 5, plus markers suggestive of CRS. Have to mention this again and again. Look hard for persistent fever or new onset of fever. Also, we need to make sure that this is not because of thrombophlebitis or nosocomial infection. If the patient has increasing oxygen requirement, plus increasing CRP, increasing ferritin trend, persistently low or dropping absolute lymphocyte count less than 1, and high interleukin-6 level if available. So additional treatments that we use for CRS, IV Dexa or IV methylpred or IV tocilizumab. I think the most important part is actually ensuring that the patient, as inpatient, being monitored closely. So if the patient has pneumonia but not requiring oxygen, so category 3, in the presence of warning signs, as I mentioned earlier, vital signs needs to be closely monitored, so 6 to 8 hourly. And if there's further clinical deterioration, frequency of monitoring needs to be increased. And it has to be doctor and specialist review with regular blood taking, including ferritin and CRP, repeated chest x-ray if patient develop warning sign, because pneumonia can just progress overnight. For category 4, pneumonia requiring oxygen, preferably this patient should be managed in ICU with even tighter vital signs monitoring. And in addition to that, we do procalcitonin because we wanted to also make sure there's no concomitant bacterial infection. How about the usage of anticoagulation to prevent venous thromboembolism? So these patients are in isolation, they are on oxygen, they are advised not to move about, complete rest in bed, they have comorbidities, they are elderly. So of course, risk of venous thromboembolism is high, on top of the COVID itself being a hypercoagulable disease. So for patients, we advocate using prophylaxis anticoagulation, Clexane daily depending on renal function for all patients that requires supplemental oxygen. So this is category 4 patients. And of course, full dose anticoagulation, Clexane according to body weight VD, if they confirm venous thromboembolism or if we suspect but not able to send for CTPA because they are not stable to go down to radiology, or any other evidence from hemodynamic instability, bedside echo, whatever that can be offered. Or if they are on CRRT, in which the device always clots. So sometimes the nurses will say that we tried CVVH, but the always clots. So it is not because of the nature of the tube or because it's CVVH, but because the disease itself is prothrombotic. So we provide full dose anticoagulation. But there are these in-between groups. Oops, sorry. Where we will advocate high prophylactic dose of anticoagulation for patients in ICU. These are patients in the ward, usually, or acute cubicle. But these are patients in the ward, but they are not critically enough to belong to category 1 here. So we use D-dimers to base the judgment whether to heighten up the anticoagulation or not. Okay. So more and more evidence will come by. At the moment, we already guideline number 6 in COVID management. So we are looking forward to more evidence in terms of better treatment therapy for COVID. But this is an interesting summary by New York Times saying that there's a lot of promising evidence for the usage of IV remdesivir, an antiviral drug. We are using this as part of the Solidarity WHO trial, and also dexamethasone. There's mixed evidence for usage of favipiravir, convalescent plasma interferon, tocilizumab in COVID management. Not much promising data on Kaletra and hydroxychloroquine. A lot of controversies when Donald Trump suggested using detergents to treat COVID, and of course widely used but not much data on proning position, and of course ventilator supports in the ICU. Okay, so finally we get to discharge the patient. So what are the discharge criteria that we use? For symptomatic patient, these patients should be at least 72 hours without any symptoms, means resolution, total resolution of symptoms, being it anosmia, fever, cough, breathlessness, and at least 14 days of that incubation period have passed, or the disease period have passed since the first symptoms progress. But for asymptomatic patient, we calculate 14 days from the first positive test that was done when the patient was admitted. Okay, and for patient before they are discharged, no COVID-19 test of cure is offered. So they can be discharged after 14 days and after being asymptomatic for the period given, and continue ongoing medical care or be transferred to other hospitals to continue their follow-up there. And these are the pamphlets that we provide to patients. Of course, having recovered from a very serious infection, there will be a lot of questions, a lot of uncertainties from the patient as well as their carers. So we provide these guidelines, sort of like to tell them what they can or cannot do. And of course reiterate the importance of avoiding 3C and practice 3W. These are some of the pamphlets that we provide for our patient before they are discharged. Thank you.
Thank you, Dr. Arisa.